Osteopathic cranial manipulative medicine, or OCMM, is a treatment modality. Associated structures include the frontal and parietal bones, which articulate with one another via the coronal suture. The paired frontal bones are separated by the metopic suture at birth, and the paired parietal bones are separated by the sagittal suture. The frontal bone articulates with the nasal, maxillary, zygomatic, lacrimal, ethmoid, and sphenoid bones, forming the roof of the orbital cavity. The paired parietal bones articulate with the occipital, temporal, sphenoid, and frontal bones, forming much of the superior and posterior aspects of the skull. Just deep to these, a thick, double-layered fibrous membrane that adheres to the internal surface of the skull. To begin, we will assess the frontal bone by draping our fingers over the bone. With fingers resting gently, the physician assesses for any tissue texture changes, asymmetry, restriction of motion, or tenderness, or TART. The first technique we will demonstrate is the frontal lift. With the patient lying supine, the physician sits at the head of the table, letting their forearms rest on the table. The physician contacts the lateral borders of the frontal bone with their thenar and hypothenar eminences, taking care with placement to ensure they are engaging the frontal bone only and not over other sutures or bones. The fingers may interlace, and a gentle medial pressure is then applied through the palms of the hands to disengage the frontal bones from their articulations with the parietal bones. The physician then lifts the frontal bones anteriorly and slightly superiorly and maintains this traction until a release is felt. The frontal bones are gently placed back to their original position and then reassessed for improvement in motion with PRM and improvement in somatic dysfunction findings. To assess the parietal bones, place your hands in the vault hold, letting the mid part of your palm gently rest over the parietal bones. Again, assess for TART and any motion restriction of the parietal bones in external and internal rotation. We will now demonstrate the parietal lift. This technique works via release of somatic dysfunction at sutures or dural attachments. With the patient and the physician in the same position, the physician places the finger pads of digits 1 through 4 on the inferior borders of the parietal bones bilaterally, just below the parietal eminences, taking care not to place fingers over the temporal bone, occiput, or other sutures. The thumbs will cross one over the other above the sagittal suture and not touching the patient's head. Gentle pressure is applied from the bottom thumb into the top thumb and the top thumb down into the bottom thumb to disengage the parietal bones from their articulations. The physician will then gently apply cephalad traction by leaning back. Traction may be emphasized with different fingers depending on where the restriction is most prominent. This traction is maintained until a release is felt. The physician then gently places the parietal bones back to their original position and reassesses for improvement in PRM and somatic dysfunction findings.